everyone. Thanks for sticking around. We have another great talk planned right now. And those of you at home, hope you're ready to hear and learn some good pediatric sports medicine. So this next talk is being presented by Dr. Celina de Borja. She has been with us for a few years, and we're very happy to have her. She works mainly in the East Bay, correct?
Mission Bay.
And mainly in Mission Bay. She's a board-certified pediatrician with specialty training in sports medicine. She actually grew up in the Philippines and did her undergraduate degree and medical school there, then moved to New Jersey and did her residency training in pediatrics there. And then she attended the Harvard Medical School Boston Children's Hospital Sports Medicine Fellowship. And then she came to work with us. So she's going to talk to us about early sports specialization and overuse injuries in young athletes. Thanks, Celina.
All right. Thank you, Dr. Wingfield. Good afternoon, everyone. Thank you so much for sticking around this rainy San Francisco afternoon. For those listening online, thank you for spending your Saturday afternoon with us. It is an absolute pleasure to be presenting in this conference today alongside my colleagues. So I'd like to thank our course chairs, Dr. Wingfield and Dr. Luke, for having me today. I am tasked to discuss pediatric sports medicine this afternoon, and since my practice partner, Dr. Nirav Pandya, already talked about acute injuries this morning, I figured talking about overuse injuries would be a good idea, especially because it is something that's widely seen in the primary care setting. No disclosures for this talk. In addition to discussing overuse injuries, I also wanted to emphasize early sports specialization and how it relates to increasing risk for sustaining these overuse injuries. According to the CDC, roughly 3.5 million children are seen every year for sports-related injuries. To put that into perspective, MSK or sports injuries are top 2 reason to see their primary care provider, whether in the ER setting or ambulatory setting. That is excluding well child visits, and that's number 2 following upper respiratory infections. More than half of these sports injuries are considered preventable, and overuse injuries are responsible for nearly half of these injuries that are seen in middle school and high school athletes. As we're all trained in the field of healthcare, children aren't small adults. There are intrinsic risk factors that increase children's risk for sustaining their injuries. Specifically, they have an immature musculoskeletal system. They have increased bone plasticity, they have open growth plates, they're ligamentously lax, and they have underdeveloped muscles that can ultimately lead to poor technique. And then in addition to that, normal variants of anatomic alignment, specifically in-toeing or knock knees or flexible flat feet that are completely normal during growth and development, can also contribute to sustaining these injuries. Extrinsic or modifiable risk factors could also play a role in sustaining these injuries. So specifically, rapid increase in training or too much too fast. This is something that we all saw in the spring of 2021 after children eagerly returned to sports following a year-long lockdown. We saw this time and again, fall of 2022, when all children, or most children came back to in-person school, in-person PE, and regular sporting activities. Older studies also found, high training volume, so too much for too long, as a risk factor for sustaining these overuse injuries. So older studies that looked at high school students found that athletes who participated in sports more than 16 hours a week had significantly increased risk of sustaining these overuse injuries. However, we all know that sports is happening at a younger age nowadays. And so newer studies are seeing that athletes who participate in more hours per week than their age in years are more likely to sustain these overuse injuries. And then lastly, even if you account for exposure, even if you account for number of hours per week in organized sports, we're realizing that early sports specialization is also found to be an independent risk factor to sustaining these overuse injuries. So just curious, with a show of hands, how many have stumbled upon this term early sports specialization? All right. Early sports specialization has been around for about a decade now. The different organizations, the American Orthopaedic Society for Sports Medicine, American Academy of Pediatrics, the American Medical Society for AMSSM, and even the Journal of Athletic Training have all produced position statements about this. But it is this new training method that is followed by young athletes in the hopes of achieving elite level success. So what they do is they choose a single sport, for example, soccer. They quit all other sports, so they stop participating in basketball or football or hockey or other things like that, so that they can participate in their single sport year-round, so more than 8 months in a year. And they do this by participating in their high school team, their club teams, their rec teams, their travel teams. And there's not necessarily a specific age, for what early is defined in sports specialization. The AOSSM mentioned, specializing before the age of 12 as early, while the AAP and AMSSM has defined early as before adolescence, which we all know adolescence is a pretty broad period during a child's growth and development. And so, who's specialized? Like, where do we see these kids? An estimated, 10 to 30% of children between 12 to 14 are considered specialized. And the range is pretty broad because there's several different factors that play a role in, this practice. Traditionally, we see it in athletes who participate in individual or technical sports, such as tennis, gymnastics, dancers, swimming, and diving, with the gymnasts and dancers more commonly known as earliest specializers. However, recent trends have also shown, changes in athletes who participate in team sports, so baseball pitchers and soccer athletes specifically. Where someone lives also can influence their specialization practices. So studies show that kids in suburban regions are more likely to specialize compared to their peers in rural regions. A study shows that high school athletes are more likely to participate in more competitions, play in a league outside of their school, and train more than 16 hours a week year-round compared to those who live in rural regions. Weather can also play an important role in specialization practices. I trained in the East Coast where no one plays warm weather sports like soccer or baseball half of the year because of harsh winters. But coming out here where weather is more conducive to year-round participation, I'm seeing something similar to what research has shown, where in high school pitchers would pitch an average of 9 months in a year in a warmer weather region compared to 6 months in a year where their peers who live in colder regions do. Socioeconomic status can also influence specialization practices. As you can see on the graph over here, is that higher SES families tend to become more specialized compared to the low or middle income families. And also private insurance athletes tend to be more specialized than those on public assistance. Some of my colleagues around the country, we all work in this pediatric research and sports medicine research interest group. Some of my colleagues looked at parents and athletes' attitudes and beliefs towards sports specialization to try to see where the issue is. And what they found is that roughly 80 to 85% of the parents believe that the specialization will increase their child's chances of getting better, while only 41 to 47% of them believe that it would increase their risk of sustaining injury. Similar numbers were seen when the club athletes were asked themselves. And you may wonder how we got there. And you may wonder how the sports culture has changed, especially for our participating youth. The issue really is that youth sports is a billion-dollar industry in the United States. And it's fueled by organizations that don't always align with the long-term health and development of its participating youth. There's more focus on elite status and performance that's reinforced by social media, college scouts, professional organizations. And it's more than just organizing local, regional, or national tournaments. There's a lot of technology money involved or invested as well. So they have these apps, there's streaming services, there's a lot of these technological advancements involved in it that generate income through producing ads, and they're all at the expense of our youth athletes. An example that's closer to home is this article from the Chronicle that came out in the summer. It's about this 8-year-old boy who's really enthusiastic about basketball. And the article talks about how he's already being ranked by these websites as top 2 or top 10 for high school class of 2032, which haven't even thought about 2030s yet. Such a long time, right? But they're already creating this frenzy, for these, very well-meaning families. And so it leaves this kid's family with a dilemma of balancing, cultivating his skills and, athletic pursuits while balancing, raising 4 other children in their family. And, the other big issue is, what will come out of all these efforts if his big growth spurt never comes. So it really, puts parents and families at, at a difficult position. And while all these articles or online attention may sound very impressive, the stats actually show a different story. The chance that a high school athlete actually makes it to Division I with a scholarship is actually 1%. And not all scholarships are created equally. There's a full ride, there's partial rides. Not all sports are actually given a full ride. Specifically, soccer is not necessarily a sport that's given a full ride. The average athletic scholarship is less than $18,000, while the average tuition is roughly $22,000 and $36,000 for public and private school, respectively. And even if the child makes it to D1, the chance of playing professionally are even slimmer. And so, when families, come to you and, ask the question, do we really have to do it? Do we have to start them young? Do we have to go through all this trouble just to increase our levels of success? And studies show that it's not necessarily the way to go because early sports specialization does not ensure success in sports, except maybe, and we're still kind of working on, researching this aspect in fields such as gymnastics or figure skating or dance, wherein certain technical skills have to be developed before they're done growing. What has been found to be supportive of sports success is actually family history, considering that genes play an important role in an individual's athleticism. Here are a few studies that I'll go through that help debunk some myths about sports specialization. So Danish elite athletes versus near elite athletes were compared in one study, which found that the successful elite athletes specialized later and trained less compared to their near elite peers. Another study that looked at Olympians who participated in 2004 found that the mean age of sports initiation was actually 11 and a half years old, which is considered pretty late or pretty old in 2022 standards, unfortunately. And then an older study on NCAA Division I athletes showed that 70% of athletes did not specialize until after 12, and that 88% of them played more than one sport in high school. In addition, 40% of these athletes reported having a parent who competed at a college or professional level, further supporting our genetic theory. Newer studies on the matter, say a very similar story. This study that was published by some of my colleagues here at UCSF found that when athletes through 5 decades were examined, only about 18% of them specialized before the age of 15. Specialization is more common in gymnastics, tennis, swimming, and diving. However, this is one of the newer studies that showed the emerging trends in soccer. There was also this trend towards earlier specialization for recent college graduates. What's interesting was that there was no difference in scholarship attainment between specialized and non-specialized group, and that although their injury profile are very similar, burnout is actually higher in athletes who specialize early. Another study done by the same group, focusing on NBA first-round draft picks from 2008 to 2015, showed pretty high specialization rates amongst these NBA athletes. About 85% of them reported specializing in high school. The issues are that the multi-sport athletes are actually less likely to sustain a major injury. Multi-sport athletes are more likely to play more games in the NBA. And also have longer professional careers. And then in the baseball league, there's also pretty high specialization rates. About 49% of athletes who played in the Atlantic League in 2016 report that they specialized before high school. Athletes who specialized reported more serious injuries with regards to baseball. So by more serious injuries, these are injuries that required at least a year to recover or needed surgery. What was interesting about this study was that 63% or majority of the athletes did not believe that specialization was necessary to master the skills that they need to play at the professional level. And so the problem with early sports specialization is that lack of diversity may not allow for appropriate neuromuscular skills that are effective in injury prevention. What does that mean? So we're teaching your young baseball athlete, your young pitchers to throw faster at higher skill levels. However, they can't even run a mile or do a sit-up, right? They don't have the core strength or the cardiovascular fitness that are necessary for injury prevention. In the same manner, in the setting of baseball athletes, if they're only using their upper extremity dominant side, right, over and over again, it doesn't allow from repetitive use, because they're not playing other activities or other sports that may exercise different parts of the body. And so with that, early sports specialization has been found to increase their risk for injury. As you can see in this graph over here, this is a similar one that was shown earlier. The higher the specialization practices are, and so does the occurrence of serious overuse injuries. By serious overuse injuries, we're not just talking about anterior knee pain or Osgood-Schlatter or Sever's disease. We're talking about injuries that require at least 4 weeks of rest from sports. So we're talking about spondylolysis, stress fractures, ligamentous elbow injuries that require surgery, or cartilage injury. The degree of specialization also matters. So as you can recall, we mentioned there are 3 components to specialization. If they do 1 out of the 3 components, they have relatively lower risk for serious overuse injuries. However, if they have 3 out of 3 of those components, then their risk goes significantly higher. And then lastly, in addition to the physical issues, early sports specialization has also been associated with mental and psychosocial problems, particularly burnout or depression, pain-related anxiety or fear of re-injury, and earlier withdrawal from sports. And so now, before we move forward to the different overuse injuries that we commonly see in pediatric sports medicine, I just wanted to give a brief kind of overview of what they're all about. And they usually fall under the umbrella of apophysitis, which is overuse injury of the growth plate. So these are usually injuries that aren't preceded by any injuries. They tend to be insidious in onset. They could be intermittent or progressive. They're always worse with activity and then improve with rest. It is a unique type of injury that we see in our young athletes because of the relative imbalance that happens in their strength and flexibility as they're growing up. Usually what I would say is that their bones grow faster than their muscles, so as they're getting longer or taller, their muscles get tighter. And as you can see in the upper right corner of that image showing what traction is, usually the area of weakness is the structure that becomes symptomatic or that gives, which a lot of times in our young athletes would be the growth plates. And while families will say, well, all my children went through growth spurts at different points in time, why is this one child specifically having issues with it? And the answer is, these overuse injuries are exacerbated by increased physical demand. So it really depends on what kind of activity, how much, how often, and how intense they're participating in. And so we'll go through a few overuse injuries, from upper extremity to lower extremity. And we'll try to talk about diagnostic indications and also therapeutic options that could be available in the primary care setting. So Little League shoulder is also known as proximal humerus physeal stress injury. It is seen in skeletally immature athletes who participate in overhead activities. So it's not just exclusive to our baseball athletes. You can see it in volleyball athletes, tennis, or other activities that involve that overhead motion. It is from tractional forces to the proximal humerus physis, so it's kind of like forces that separate the growth plate. It usually is from poor mechanics or technique or high pitch counts. They usually present to you with, chronic, atraumatic, could be intermittent or progressive shoulder pain. Usually what will bring them to your office is, the fact that they can't throw as much, they can throw as fast, or, they're just fatiguing earlier when they're practicing or when they're competing. On exam, they may have full range of motion if they come to your office early on. They may not have any symptoms with your rotator cuff testing, but one thing that's very unique about them is they will be very tender over their deltoid or their proximal humerus where that physis is. Technically, Little League shoulder can be diagnosed clinically through history and physical exam. However, if you were to do any diagnostic imaging, for example, symptoms have been going on for a while, then one view, an AP and external rotation of the shoulder may be helpful, which can show widening, sclerosis, or fragmentation at the growth plate. If in doubt, you can always take contralateral X-rays of the uninjured or non-dominant arm to compare. MRI is not always indicated. However, sometimes we tend to obtain these advanced imaging. It could be for prolonged symptoms, atypical presentation, or to see other pathology that may be contributing to their symptoms. But it's not necessarily indicated. But if obtained, they may show edema at the physis. We sometimes get advanced imaging because we have to get the buy-in of the families of their diagnosis to really convince them of the treatment, because the treatment for these upper extremity overuse injuries tends to be a little painful, which is rest from their overhead activities for up to 3 months, which is a long time, almost the entire season for these baseball kids. It's because it is a bone injury, it's essentially a growth plate fracture. We rest them from throwing for about 6 weeks, and then we initiate physical therapy that has a gradual return to throwing program for another 6 weeks, which brings us to that 2 to 3 month period. One thing I've learned to negotiate with these athletes is if there are activities that don't worsen their symptoms, so if their symptoms are exclusively with overhead throwing, and maybe hitting and running bases, or exercising core, cardio, endurance, and lower extremity are well tolerated, then I allow them to exercise in that manner. In that way, they're not completely deconditioned after they heal in 3 months. We expect Little League shoulder to resolve with skeletal maturity. There's about 7% rate of recurrence. But there's no reports of growth disturbance out of the research that's been published on the topic. And prevention really lies on early intervention, education, talking about pitch counts and age-appropriate pitching techniques, working on biomechanics, and then again the preventative techniques such as core strengthening and cardio fitness that a lot of these overhead athletes may lack on. Moving down the upper extremity is Little League elbow, so also known as medial epicondyle apophysitis. Just like in Little League shoulder, it's not exclusive to our baseball athletes. I've also seen this in the football quarterbacks, right, who have a high rate of throwing during practice and competition. It is traction apophysitis at the medial epicondyle by the common flexors. It's usually experienced in this maximum external rotation position in early acceleration or late cocking phase of the throwing biomechanics. They present very similarly. They only have elbow pain on the medial aspect, and it's provoked by that throwing maneuver. Other activities may not necessarily provoke it. And they're very point tender over that bone. So if you ever feel your medial epicondyle, it sticks out in your medial elbow, and that's where they're point tender. Again, these overuse injuries can be diagnosed clinically. If you were to get x-rays, you may see some widening in that growth plate, some sclerosis or fragmentation if it's been happening long enough. We see that usually. And then treatment is very similar. Rest from throwing for about 4 to 6 weeks, followed by physical therapy with a gradual return to throwing program. We expect return to competitive sports in about 8 to 12 weeks, which is similar to Little League shoulder. If untreated, they run the risk of having an avulsion fracture. So as you can see on the photo on the right lower corner, the medial epicondyle got pulled off of the distal humerus because of a forceful throw. If anyone presents with a painful pop while they're throwing, I know we always think about UCL tears or injuries in adults. Think about an avulsion fracture in a child because, again, the growth plate is the weak point in that kinetic chain. Prevention, again, includes early intervention, education, throwing biomechanics, and core strength and cardiovascular fitness. All right, so gymnast wrist is an overuse injury of the distal radius physis. We see it mostly in gymnasts who perform axial loading and hyperextension at the wrist. It causes traction force on the physis, which is, again, the weak point. Similarly to the other overuse injuries, they'll present with atraumatic, chronic, intermittent, or progressive wrist pain. Some of them, it's been going on for a few weeks to even months because they think in the gymnastics community that wrist pain is completely common and normal, and so they'll eventually present to you in a chronic manner. They may have some focal swelling over their distal radius. Again, this is a bony injury, and so there can be physical or external signs with it. And the thing about them is they're, again, focally tender over that distal radius by the physis. X-rays may show widening at the physis with irregularity or sclerosis or fragmentation at the borders. When in doubt, you can always use X-rays of the contralateral wrist to see if there's similar findings. MRI, just like in Little League shoulder, we use it if symptoms are chronic, there's not response to treatment, or try to see if there's anything else going on. Most of the time, if it's gymnast wrist, we'll see paraphyseal edema and early physeal bridging. Treatment for gymnast wrists also involves at least 6 weeks of rest. Again, this is a bony injury. It is considered, a growth plate fracture, and so we immobilize them for about 6 weeks. That's how long it takes for bones to heal. Because gymnasts are very hard to shut down, they're usually in the gym 20 or so hours a week. They're pretty difficult to shut down. Most of the time, we put them in a short arm cast just to really rest that distal radius physis. And then we encourage gradual return to sport and working on strength, flexibility, and technique upon return. We expect successful return to sports for gymnast wrist if treated early, but some can take 4 to 5 months to get better, especially if they're late to care. The issue about gymnast wrist is there's about 12% rate of recurrence with 10% rate of growth disturbance. And so what happens is if there's growth disturbance to the radius, sometimes the ulna overgrows, and there's some ulnar variants that can cause chronic wrist pain in the future. And about 3% of these growth disturbances may require corrective surgery. And so that's why we're more proactive in treating these overuse injuries compared to other parts of the body. Prevention includes education, load management, exercises, and then technique training. Moving down to the lower extremity, we also see, anterior knee pain very commonly, actually more commonly than our upper extremity overuse injuries. They will say, it hurts to run and jump, and, it's better when I'm resting. Sometimes it's relieved by ice or ibuprofen. If there's no report of an acute injury or the acute injury doesn't seem to make sense with their symptoms, then you're more likely, dealing with an overuse injury or apophysitis of the anterior knee. If they're focally tender at the proximal tibia, then that's your classic Osgood-Schlatter, which is more common apophysitis in the anterior knee. However, there's also this other condition called Sinding-Larsen-Johansson syndrome, which is apophysitis at the inferior pole of the patella. So same exact mechanism, same exact presentation, just different location. These conditions can be diagnosed clinically. However, if you were to take x-rays, you may see some sclerosis and fragmentation at the growth plates. The appearance that you see on the screen over there are completely normal growth plates. If there is no evidence of acute injury that caused their symptoms, or especially if there's no injury that cause, impairment in the extensor mechanism, then it is very unlikely for, this to be an avulsion fracture. And I just wanted to share that with you all because we do get, radiology reports sometimes that say, could be overuse, cannot exclude, avulsion fracture, and then, it puts parents in a panic, wanting to see us urgently because they were told that their, child had a broken bone, but in reality, it really is, a normal finding. Treating lower extremity overuse injuries were a little bit more forgiving. I think the outcomes are a little bit better compared to upper extremity injuries, and so we counsel them about activity modification so that they're not completely, restricted from, running or jumping sports, but ultimately, we just tell them to avoid or lessen the, exercises that, worsen their symptoms. We emphasize the importance of, flexibility exercises, especially quad and hamstring stretching, because again, this is something that's, growth related, their soft tissues are getting tight, and we don't want to stop them from growing, but at the same time, these muscles and soft tissues lag about a year or two behind in terms of length. And so, what I tell them is, I don't want you to stop growing. I also don't want you to stop sports, but I want your muscles to kind of keep up with the amount of growth that you're getting. Supportive measures, ICE and NSAIDs could be helpful for symptom management, and then a TROPAD or counterforce strap can also be used for when they're participating in sports. We expect these symptoms to, wax and wane, but ultimately resolve once they're done growing. I think, this expectation is very important because a lot of times, they get diagnosed with Osgood-Schlatter, they're treated appropriately at the primary care level, and then they kind of come back the following year and they, demand to see a specialist because it came back. And, a lot of times I tell them, well, you were treated appropriately, I would have done the same exact thing, and it came back because it can come back. So I think, some expectation management, would be helpful in also like convincing them to really invest in their, treatment protocol. Also let them know that the bump on the proximal tibia may never go away. So the bump is part of your body's response to the, chronic traction or micro injury. And so even though they're fully grown, the symptoms have gone away, that bump might stay there. So just let them know about that as well. And then if untreated, just like in the elbow, you can have an avulsion fracture, at that proximal tibia with an extensive, extensor mechanism action. And then prevention really lies around, flexibility exercises during growth spurts. So I just wanted to mention avulsion fractures a little bit because I feel like it's something that's less understood because the mechanism and we see it in a very unique setting. So an avulsion fracture of the proximal tibia is something that we think about if someone experiences a painful pop or snap or rip in their knee. That's usually non-contact, but it can be contact as well. But it's essentially caused by extensor mechanism or quad activation. So a forceful jump or, like a forceful kick in sports can, cause these injuries. They usually present with very acute pain, a lot of swelling, limited range of motion, and difficulty weight bearing. They may or may not have history of Osgood's, for this to happen. An avulsion fracture, if that's something you're suspecting, I highly encourage getting x-rays for this. The lateral view will show the degree of displacement of the tibia tubercle. For fractures that are minimally displaced or displaced less than 2 millimeters, we can treat that non-operatively. So we lock them in either a cast or a hinged knee brace in extension for about 6 weeks because, again, it is a bone injury. And then we send them to physical therapy because we all expect them to be weak and stiff after being immobilized for 6 weeks. If the fracture is displaced, especially in this photo over here where there's an intra-articular component that's considered unstable, we need to treat them surgically through fixation, soft tissue repair, and that's when we refer them to our colleagues. All right, so young kids who complain of ankle pain or heel pain, especially if bilateral, think about Sever's apophysitis, which is traction apophysitis at the calcaneus by the Achilles tendon. Sometimes repetitive impact on the heel is also a factor that, can cause these symptoms or these injuries. Again, there's no trauma or injury prior to the onset of symptoms. They've just been, happily playing soccer, and then their, heels start to hurt. One of the things that could be seen is, again, widening and fragmentation of the calcaneus. The calcaneus in a skeletally immature kid just always looks irregular. And so, again, in the absence of an acute injury, especially a high-velocity injury. So, the times I've seen actual calcaneal fractures, it's usually like a big fall, like someone jumped off a 10-foot ledge or something. And so if there's no story of anything like that, I know sometimes, they're told, oh, your growth plates are open, I don't know if it's broken or not, then it's more likely that, they have an overuse injury. So, just, base it on history and clinical exam. They're usually very, very tender at the heel. And so the way we treat these are, through activity modifications, flexibility exercises, supportive measures, and then heel cups can also help with alleviating their symptoms. Symptoms, just like any other overuse injury in kids, will wax and wane, but will ultimately resolve over time. We don't usually see any long-term issues into adulthood. Sometimes the kids, find a hard time stopping their sport, or don't even tell their parents that their heels are hurting until their parents realize that they're limping on the field. And so in some cases, they can't even walk on their heels. They're tiptoe walking or they're limping. Sometimes we put them in like a cam boot or give them crutches just to offload that heel a little bit. Prevention includes a lot of flexibility exercises, especially ankle dorsiflexion during periods of growth, and then we encourage limit use of cleats or running time on hard surfaces if they're suffering through Sever's disease. All right. So lastly, I'd like to present Island disease, which is an apophysitis or overuse injury that is seen at the foot. It's usually young athletes or dancers who do a lot of forefoot movements, and so dancers, gymnasts, figure skaters, do a lot of forefoot movements. It is because, there is a growth plate at the base of your fifth metatarsal where your peroneus brevis attaches to. Island disease is something that could be diagnosed clinically. They're very point tender over that base of the fifth metatarsal. They can have pain when you passively invert their foot, or they can have pain when you do resisted eversion. In the absence of an acute injury, you may diagnose them clinically. However, if there is any suspicion for an acute or inciting event, then I highly encourage getting x-rays for these because you can find fractures. So, if they say I've had this foot pain, my whole time I was dancing, and then I, had that one jump and then felt something crack or snap, think about getting x-rays, think about a stress fracture. If, they say they rolled their ankle, but their ankles are completely, benign, there's no swelling, there's no bruising around the malleolus, and they have tenderness over the fifth metatarsal, think about, getting x-rays to check a fracture. When you get x-rays, the growth plate looks vertical like this in the right lower corner of the picture. So if it looks vertical like that and there's no acute injury, it's more likely just overuse. If you see a horizontal or a diagonal line, especially if there's an acute event, think about an actual fracture. So treatment of Island disease includes activity and footwear modifications, physical therapy exercises that focus on the calf and peroneals, ice and NSAIDs for supportive measures, and taping techniques. Symptoms will also wax and wane, but ultimately resolve over time. Some people may have a bony prominence at the base of their fifth metatarsal. Again, it's part of the body's response to chronic traction. For the most part, they remain asymptomatic, so we don't really need to do anything about it. And then prevention involves a lot of ankle strength and flexibility exercises and making sure that they have appropriate shoe sizes as their feet are growing. All right, so in summary, pediatric patients are at risk for overuse injuries due to both intrinsic and extrinsic factors. Early sport specialization increases their risk for serious overuse injuries. And so I just wanted to emphasize that today, because a lot of these overuse injuries are very simple and straightforward to diagnose and manage. However, if you don't deal with the underlying issue, then they'll keep on coming back. And may also be associated with other wellness or mental health issues such as burnout, depression, anxiety, or ultimately withdrawal from sports. And so lastly, I'd like to share some recommendations that we always remind our families of in pediatric sports clinic. So one, we encourage early diversification. So trying out different sports and see what they like so that it develops different parts of their body. We encourage free unstructured play because with free play, they're allowed to self-regulate. There's no coach, there's no teammates, there's no parents kind of pressuring you, and so they're allowed to just play and be kids. So we encourage that. Load management is very important. Quick and dirty rule is keep your number of hours per week, less than your age and years. Take breaks from organized sports at least 1 or 2 days a week, and 2 to 3 months per year. So that break may be divided into 1 month increments. They don't have to be couch potatoes during these breaks. They can be in recreational or unstructured play during these periods where they're allowed to self-regulate and not go into overuse. And then lastly, we're still working on research that will help us understand age-appropriate, sports participation for our young athletes, especially, the early specializers. But for the most part, we tell them that, early high school, it's good time to maybe think about, specializing versus being a recreational athlete. And then, late high school is usually when we think that they're, physically, socially, and emotionally mature to invest in a single sport. And so with that, I'd like to thank everyone again for sticking with us this Saturday afternoon. If anyone has more interest in pediatric content, we have a course coming in March of 2023. It's all dedicated to pediatric musculoskeletal and sports medicine. We have an all pediatric faculty from orthopedic surgery, rehab, rheumatology, neurosurgery. We have PTs, OTs, and athletic trainers as part of our faculty. So we are really excited that it will be in person for 2023, and we all hope to see you there.
Thank you very much, Dr. De Borja. Do we have any questions in the room? I'll come over with the microphone.
Hi, thank you. That was a great lecture. Forgive my ignorance, but how do you differentiate what is epiphysitis versus what would be like a tendonitis, like a jumper's knee, for example, versus your Larsen-Johansson's? Is it mostly X-ray finding? Does that really change a treatment plan? As I'm a pediatrician, general practice, so I tend to refer out, but I'm curious.
Great question. So in terms of diagnosis, it really is just location. So if it's at the inferior pole of the patella, so like still bony part, or the proximal tibia, so again, bony attachment, then that's when we call it apophysitis. If it's hurting directly over the patellar tendon, then that's how we diagnose patellar tendonitis. You're completely right. Management is very similar. Flexibility, load management, and supportive measures. So kind of same spectrum, just like different diagnosis because of the age and the structures.
Hi, so 2 questions. First, with the little leaguer's elbow, is there any association with people who have that subsequently keep playing baseball and perhaps need a Tommy John, or is that not a thing?
There is, yeah. So there are, the reason why we're stricter with the upper extremity overuse injuries is because outcome studies have shown that they're more likely to sustain serious elbow injuries like OCDs and UCL tears. So studies have shown if someone has little league elbow and doesn't want to stop or rest or rehab, they're more likely to need, they're more likely to sustain an injury that will need 1, longer recovery, from sports, and then 2, probably a surgical procedure. So that's why we, advocate for, listening to the athletes. If we don't want them, playing through pain, we don't want them, going over their pitch counts and things like that, because the outcome studies show that it could be detrimental for them down the line.
Okay. And the second question, in my past life, I guess, I was a doctor for Marine Corps units, and I spent a lot of my time with infantry. And with that time, I also spent a little bit of time in the Marine Corps boot camp down in San Diego. Mm-hmm. And even though technically they're like 18, they're definitely still pediatric in nature with a lot of issues. I feel like a lot of them had almost every single injury you said, especially lower extremity stuff. So do you have any perhaps clever ways to say, we obviously have infantrymen or any other military member who can't take 4, 6, 12 months off things? Is there anything that could be done to help prevent injuries in people like that that just don't have the ability to take that much time off, yet also are very high risk to have almost all of these injuries?
Right. I think definitely you would think of them in the pediatric age group for sure, but I think the principles remain the same. Too much too fast, too much for too long, and repetitive body parts. Right, that's kind of the theme of overuse injuries. So I think to help those individuals, I think thinking about cross training, right? I guess in their routines, if they need to stay physically fit, does it always have to be, high impact activities? Is there room for medium impact or low impact activities, right? To help them stay fit. And then also, thinking about injury prevention strategies. So making sure there's a good balance between strength and flexibility. So as we all know, when kids are younger, they're all loose goose, right? They are very flexible, they're not strong. And then as their bodies change, right, when we build muscle, when there's hypertrophy, there's more strength, but we lack or, we lose flexibility. And so I always remind, athletes, whether they're young or old, to try to find that balance, because each end of the spectrum increases your risk for injury, and sometimes, just finding the balance will help you get to a happier place.
Thanks.
Thank you.
I would just comment on that as well. I think part of that culture is to not stop and to go through pain, and trying to change these cultures. And even in sports like baseball, where kids don't want to tell their coach when their arm hurts, trying to change the culture where you should report your pain early because you'll have less time off if we can rest you at the beginning, versus if you go till you drop and then you have a fracture and you're off for 3 months. Hard thing to change.